Good morning, everyone. My name is Maisha Hutton, and I am with the Healthy Caribbean Coalition. I'm the Executive Director, and we are very pleased to bring to you today a webinar on celebration of our second annual Caribbean Alcohol Reduction Day, Drink Less, Reduce Cancer. This is brought to you by the HCC in partnership with our partners, the Pan American Health Organization, PAHO, CARPHA, and CARICOM. So we are really pleased to be having the second annual Caribbean Alcohol Reduction Day, really highlighting the importance of alcohol and NCDs. And this year our focus is on the link between cancer. The objectives of CARD this year, as we like to call it, are to really increase public and policymaker awareness about the harmful effects of alcohol misuse, and also about the links between alcohol consumption and cancer, and then finally to call on policymakers to make specific policy actions in 3 areas, which are consistent with the WHO Best Buy interventions: increasing taxation, enforcing bans on restrictions around alcohol advertising, and restrictions on the physical availability. So today we're really honored to have 3 excellent presenters with us. We've got Dr. Kevin Shields, Dr. Maristela Monteiro, and Dr. Rohan Maharaj. First, we're going to hear from Dr. Kevin Shields, who is an independent scientist at the Institute for Mental Health Policy and Research. He's the head of the WHO PAHO Collaborating Center, which is the Center for Addiction and Mental Health. Dr. Shields will be talking to us today specifically about the burden of disease caused by alcohol consumption as a key health problem confronting all countries.
Hello, everyone. My name is Shields, and I am the head of the WHO and Pan American Health Organization Collaborating Center at the Center for Addiction and Mental Health in Toronto. And today I'm going to present to you work that my group and I have done on characterizing cancer, alcohol consumption, and the burden of cancer due to alcohol consumption in the Caribbean. Next slide. Specifically, this presentation is going to cover 5 different topic areas. 1, the profile of cancer in the Caribbean. 2, how alcohol consumption is causally related to cancer. 3, how much alcohol consumption is in the Caribbean and why it's a problem. 4, the number of new cancer cases and cancer deaths attributable to alcohol consumption. And lastly, I'm going to be talking about how the unnecessarily high burden of cancer in the Caribbean can be prevented through effective public policy measures that combat harmful alcohol consumption. Next slide. So in the Caribbean in 2012, this is the year that IARC has for the latest data availability. 21,000 new cancer cases and 13,000 new cancer deaths occurred. But more importantly, what you can see is there's a large heterogeneity between countries, with Barbados on the top and Haiti on the bottom. And what this is due to is lifestyle risk factors. So tobacco smoking, obesity, lack of physical activity, diet, and of course, cancer. Next slide. So how do we know that alcohol consumption causes cancer? Well, international agencies evaluate the causal link between alcohol consumption and cancer by looking at the molecular evidence, so down on the cell and molecule level, as well as the epidemiological evidence on how alcohol consumption affects the risk of cancer. And through biological pathways, we know that alcohol consumption causes cancer through the metabolism of alcohol, the inhibition of the 1-carbon metabolism pathway, and modification of hormone levels and associated signaling pathways. And because of this and the epidemiological evidence, the International Agency for Research on Cancer and many other national and international organizations have deemed alcohol as a class 1 carcinogen. And what this means is there's the highest level of evidence to suggest a causal link between alcohol consumption and cancer. For reference, tobacco and lung cancer, as well as other cancers, are also in that group. So we know that alcohol consumption causes cancer, but at what sites does alcohol consumption cause cancer? Well, alcohol consumption causes cancer of the oral cavity, the oral pharynx, the hypopharynx, the larynx, the liver, the colorectum, and the breast, as well as the esophagus. So you'll see that most of them are digestive tract cancers, but you also have breast cancer, and that's where alcohol consumption affects the risk through modification of hormone levels. Next slide. So cancer is a problem in the Caribbean, and alcohol consumption leads to cancer. So how much alcohol is consumed in the Caribbean? Well, on average, an adult drinks about 1.2 standard drinks of alcohol per day. And this hasn't changed much since 2002, if you look at the difference between 2002 and 2014. But what's important to notice here is that there's a heterogeneity between countries. And what this heterogeneity or difference between countries and alcohol consumption suggests. So on to the next slide after alcohol consumption. So there's a large burden of cancer in the Caribbean, and alcohol consumption in the Caribbean is actually relatively high. So how does alcohol impact cancers in the Caribbean, and how much of that heterogeneity between countries we see in the crude cancer rates are due to alcohol consumption? Well, when we look at the number of new cancer cases attributable to alcohol consumption in the Caribbean, we see that 3.1% of all new cancer cases are attributable to alcohol consumption. So what that means is that 3.1% of all those cancer cases wouldn't have occurred if everyone was a lifetime abstainer. But more importantly, what we see is we see a large heterogeneity between countries. Again, this suggests that the burden of alcohol attributable cancer in these countries is unnecessary. Next slide. When we look at cancer deaths attributable to alcohol consumption, the story is very similar. 2.9% of all cancer deaths in the Caribbean in 2012 were also attributable to alcohol consumption. However, when we look at the heterogeneity, it's a bit less, and this is because of a confounding factor. When we look at cancer incidence, it's a direct link between alcohol consumption and the development of cancer. However, what's also an important factor to take into consideration when looking at cancer deaths is the survival rate. But nevertheless, even with cancer deaths, we see that there is an unnecessary burden of cancers attributable to alcohol consumption in the Caribbean. And when we look at the relative magnitude of 3.1% of all new cancer cases and 2.9% of all cancer deaths, this is in line with other major cancer risk factors, such as physical activity, obesity, and diet. However, it is below the #1 risk factor, which is tobacco. Next slide. So we know the burden of alcohol attributable cancers is high in the Caribbean, and we know that there's a heterogeneity between countries. But what about between cancer sites? Well, if we look at the #1 cause of new cancer cases attributable to alcohol consumption, so the #1 cancer site impacted by alcohol, we see that breast cancers are #1, lip and oral cavity and pharyngeal cancers are #2, and colorectal cancers are #3. A similar ranking is seen with cancer deaths, however slightly different. What's important to note here is breast cancer. Breast cancers occur predominantly among women. And therefore, what we see is that when we stratify the number of new cancer cases and cancer deaths attributable to alcohol consumption by men and women, women experience a relatively equal amount of new cancer cases and cancer deaths attributable to alcohol consumption, as do men. And what's important to consider here is that women actually consume less alcohol than men. So on a gram per gram basis for total cancer risk across breast cancer, and when you can incorporate that into the overall cancer risk, women have a higher risk of cancer than men do when they can increase their alcohol consumption by 1 drink, 2 drinks, or 3 drinks per day. Next slide. So what our research has shown is that the number of new cancer cases attributable to alcohol consumption and cancer deaths attributable to alcohol consumption in the Caribbean are high. But how do we prevent that? How do we go from the current situation that we have now to a situation where we have a lower social, economic, and health burden due to alcohol consumption? Well, the Sustainable Development Goals implemented by the United Nations gives us a clue. There are 3 cost-effective but also feasible interventions that countries can implement that can reduce harmful alcohol consumption and act as an effective method of cancer prevention, namely restrictions on physical availability, advertising bans, and increases in excise taxation. The bad news is that many of these countries haven't fully implemented these policies. The good news is that the burdens caused by alcohol consumption, and specifically the cancer deaths and new cancer cases caused by alcohol consumption in the Caribbean, can thus be reduced simply by implementing these policies. Next slide. So overall, the research I have presented today indicate that alcohol consumption leads to a large cancer burden in the Caribbean. Specifically, 3.1% of all new cancer cases and 2.9% of cancer deaths are attributable to alcohol consumption. The main sites impacted by alcohol consumption are breast cancers, lip, oral cavity, and pharyngeal cancers, as well as colorectal cancers. The important part here is to focus on breast cancers, which leads to gender inequalities. Lastly, this burden of alcohol attributable cancer in the Caribbean is unnecessary and can be reduced through strengthening alcohol policies, which is an effective measure of cancer prevention. Next slide. Lastly, I'd like to thank my collaborators who have participated and undertaken this research at the World Health Organization, the Pan American Health Organization, the International Agency for Research on Cancer, and the Center for Addiction and Mental Health. Thank you.
Let's go ahead, Dr. Monteiro, with your presentation, and we can just leave the questions until the end. So let's go ahead with Dr. Monteiro, who will be talking to us about the policies around alcohol in the Caribbean.
Okay, so good morning, everyone. My name is Maristela Monteiro, and I'm the Senior Advisor on Alcohol and Substance Abuse at the Pan American Health Organization. And I want to congratulate the Healthy Caribbean Coalition for organizing not only this event, but taking the leadership in the region to have a day dedicated to alcohol advocacy, basically, and awareness. I think this is fundamental to begin changing social norms, social acceptance, and better understanding the role of alcohol on public health problems and the solutions that are available. So I'm going to talk a little bit about the status of not only the Best Buys policies that Kevin just mentioned, but the broader picture of alcohol policy in the Caribbean, and add a little bit more on the perspective on why we're seeing this situation that he just presented. Next. So as he mentioned, alcohol is linked to not only cancers, but other non-communicable diseases, and this is why alcohol became one of the leading of the 4 risk factors for NCDs, and it's part of the global framework and voluntary targets to be achieved by the year 2025. And that has been established and agreed upon internationally and includes a relative reduction of 10% in harmful use of alcohol. Next. And before this global framework on NCDs was proposed and agreed upon, the WHO had passed a global strategy in 2010 on reducing harmful use of alcohol. It was a long process of negotiations, but consensus building and consultation around the world, and it represents a very positive development globally on a common objective of reducing harmful use of alcohol. Next. It contains 10 policy areas that are all based on the best evidence available. They are all recommended by WHO, and the idea is that countries would implement the most number of these 10 to be able to effectively reduce alcohol consumption and related harms. In red is the 3 areas which Kevin mentioned, but to pass legislation, to implement these policies, you do require other policies or activities to happen at country level, starting with leadership, with a champion or an agency in charge of alcohol-related topics and that can coordinate across sectors and within the health sector a consistent and coherent message regarding alcohol. Health service response is needed, community action. Many of the policies that are recommended, for example, on availability of alcohol, require local action. They're best implemented at the local level. And therefore, supporting local action is important. We also have drink driving countermeasures because the same amount of alcohol that is linked to NCDs, as we have seen, and in cancer, are also a leading cause of injuries, particularly traffic injuries, and there are policies that can be best implemented also along the road or to prevent that from happening. And so on, reducing the negative consequences of drinking, preventing intoxication, and regulating the illicit market of alcohol or better controlling the market overall are also important. Next. So here, just a brief overview that WHO did this analysis to come up with the best buys, with an analysis of how much of the burden of alcohol could be averted and the cost involved, and the 3 policy areas on restricting the access to retailed alcohol, enforcing bans on alcohol advertising or regulating alcohol advertising, promotion and sponsorship, and raising taxes on alcohol with a public health purpose, not only to increase revenues, were the ones considered the best buys, the most feasible, and in particular for low and middle income countries. Next. And here is an overview of the policies currently in the Caribbean, and these are based on the last global survey on alcohol and health that is sponsored by the WHO in collaboration with PAHO. So we contact each country, and a counterpart is nominated and responds in consultation with other people in the government, a survey. And based on their responses, the global status report, our regional report, and other information products are prepared. So this first one shows on national policy in place. As you can see, there are very limited number of countries that have a national alcohol policy. Next. Most countries do have a licensing system. That means that the businesses that want to sell alcohol need to obtain a license. That is only one component of regulating the availability of alcohol, because a license needs to have a cost compatible with the profits that the business will have. It should be considered a privilege, not a right, just like driver's licenses. So the business should have a number of responsibilities for having that license that can range from having certain conditions where they sell alcohol, illumination, sanitary conditions, but also they can be liable for selling to minors and selling to intoxicated patrons. Just having an educational campaign or train bar owners or restaurant owners or supermarkets to not sell to minors, for example, is insufficient if there are no penalties and consequences that could push people to really enforce the law. The licenses sometimes are given without a time to expire, or they not used by public health in a way that can lead to better control of where and when, at what times the alcohol is sold. So this is just one component of the situation, but it's one that it's good compared to other policy areas. Next. And part of the availability is restrictions on hours, locations, and days where you can sell alcohol on the premise, but also off premises. These are all related to regulations that countries can implement. And here we see that only 3 countries are considered in the green arrow, that they have some regulations in hours, in locations, and in days, and some have nothing, and the majority have a situation in between. They may have regulated some hours, some locations, or some days. However, for all of the countries, the problem of enforcement is large, because often these regulations remain on paper and not always are implemented as they should. Next. Minimum drinking age to purchase, to drink, to consume alcohol is also considered part of the restrictions of access to alcohol, and is important because many people are concerned with the drinking of minors, and the earlier you start, you can increase your risk to actually become dependent later on. And we also know from neuroscience about the vulnerability of the brain of adolescents and children, and the need to avoid even small amounts of alcohol at early age. And as you can see, we have 18, the most typical, but we still have some countries that have 16 as the year, and others that don't have any. And 18 is also relatively low limit age. It is the most common, but we should remind people that it can be increased as well to 19, to 20, to 21. These are all possible to be done through laws and reviews of the laws. Next. Taxation, which is a policy that can create revenues to governments at the same time that it can reduce health problems from alcohol. As you can see, we are not in a good situation in the region. Most countries may have some tax, but it's not adjusted to inflation, or they were implemented many years ago, and therefore are not having the public health impact that they should or they could. So it's important to consider that because it is one that countries can profit and can, if properly discussing and involving the population, people in other countries from other studies have shown to support that measure. Next. And we also have advertising restrictions. This is the area that has the least development in the Caribbean, but overall in the whole region. As you can see in the slide, this is just an idea in national TV. Next. You have sponsorship of youth events, of concerts. Also, there is basically no regulation currently in the Caribbean. Next. And I want to bring back the issue of how this policy situation might be having an impact on the drinking of people and young people. Even though today we're celebrating alcohol and cancer that happens later in life, the habits and the lifestyles and the consumption patterns of people start much earlier in life. And we did a reanalysis of the global school health surveys done in the region, and about 20% of the students report that they are exposed daily or almost daily to alcohol advertisement, which is a measure that a sign that of the policy that is inexistent. And that exposure was associated with increased risk of 2 to 3 times of being a drinker and of having consumed at least 5 drinks once a month. And these are among 13 to 15 years old, so a very worrisome pattern of consumption at very early age. Next. Also, students were asked about where they obtain their alcohol, and indeed, at that young age, most people get them at home or from friends. But what was interesting in our analysis was that when young people are able to buy in a shop alcohol, they are at 3 times increased risk to be a heavy drinker already at that pattern at a young age. Again, the lack of policies or lack of enforcement of policies have a major impact on consumption, and we expect that consumption will lead to harms. It's a risk for acute problems, but also chronic problems because we expect people to continue to drink that way. Next. Another measurement of the pattern of drinking in the region is on the prevalence of alcohol use disorders. These are data just for the whole region, and it reflects the Caribbean as well, is that the prevalence among women for alcohol use disorders in the general population is the highest in the world. And that is, again, very worrisome because in general, in terms of consumption and harms, the European region has way higher consumption, and the burden is higher, and often the region of the Americas comes second. This is the only indicator, the prevalence of alcohol use disorders, or that means having alcohol abuse or dependence as a criteria, a diagnostic criteria. Among women is the highest in the world. Next. So that leads to the third factor to me, that is not only the lack of the easy access to alcohol, drinking that's starting early, the average age of drinking, also very young people in the Caribbean are drinking higher amounts, and but also the exposure to the marketing. And the marketing can include just ladies' nights, drinks for free, and other promotions targeted specifically to women. There are also promotions, of course, to men to drink excessively, use of T-shirts, sponsorship of all sorts of events. It can be the logo anywhere, and in addition to in all types of media, from TV, radio, shows, and also the internet and social media, used by the alcohol industry to promote drinking. And I'm going to give some examples. Next. Oh, here, just one study, this is a study from the U.S., but that shows that over time, the indirect promotion or sponsorship of product placement in movies for youth have increased much more than for adults. Actually, we see that adult movies show less alcohol than youth movies, and that indicates a targeted strategy to reach young people. Next. And here just examples of advertisement that in a way utilize women for to promote drinking to men, but also several of the next that are specifically targeted to women. Next. For example, associating alcohol with benefits like being an antioxidant or having low calories and to avoid obesity, this type of promotion. Next. Or now to promote drinking as a resolution of problems. If you're sad, you can drink and become happy, or to associate success and being equal to men in the workplace, in equality that we all look forward to, but using that concept to promote drinking, as you can see on the right side of the slide. Next. These are all ads from the internet. They're all from the Caribbean, and also showing associations with sports, with shows, with celebrities. Next. This is an image from a carnival in Barbados, and as you can see, the women carry the mugs and the cups, and they're not only carrying the logo of a company, but also they can drink for free. Next. And the final is the association between alcohol and cancer, and in a very perverse way, I would say, because at the same time that the same people that are patrons and support Breast Cancer Awareness Month or prevention of cancer among women are promoting drinking and promoting the several ways of drink to prevent cancer, when, as was clearly presented by Kevin, alcohol is a carcinogen. Next. This is the pink vodka. So during the month of breast awareness, there are a number of events all over that promote drinking in theory to prevent cancer. Next. And we have done work specifically on alcohol marketing regulation. We reviewed all the evidence available. We brought together experts from the region, and we summarized the evidence in a report, and that was also published in a series of articles of the Addiction Journal in January this year, and demonstrating that youth are more exposed than adults to alcohol advertising in various kinds of types of media. The self-regulatory measures of the industry are ineffective and they are regularly violated. The more youth is exposed to a specific brand even, the more they're likely to initiate early and to drink more. And the marketing itself increases the purchase and consumption of alcohol, and that's how you link with the harms that we see. Next. So just to summarize, that we have a link here that people can access to the 2 reports that we produced, and also to all the articles published in the Addiction. It was an open access issue and can be downloaded for free. Next. And going back to the policy areas, one that we have little information from countries, and we know we are far from getting there in terms of application, implementation of a health service, comprehensive health service response to alcohol problems, but it's important to include quite regularly in primary health care in any visit that people have to check up, and not only it can be in their workplace and other places in the health services themselves, to ask about consumption, to evaluate the risk, and provide, when necessary, a brief intervention if the person is open to it. These early interventions are proven to be effective and can have a public health impact, but they need to be widely implemented on a regular basis. It cannot be just 1 or 2 services or doctors who decide to do that. They do not need to be done by doctors, actually. It can be nurses, social workers, anyone trained can provide those interventions and can help with the assessment, and it doesn't take much time. And the focus on treatment of dependence only is only a partial and very small contribution to the whole response from the health sector, because what we know is that many people, actually most people who need treatment by their current situation of harms and consumption, do not want to go to treatment because of the stigma and social acceptance of alcohol problems. So we need to invest on early people before they become dependent. Next. And just a reminder that alcohol harms not only the drinker, but also other people. And it can be from a passenger, a pedestrian, can be a family member, can be a co-worker, can be a stranger. Fights in bars, in restaurants between people, domestic violence, child negligence, and in the workplace, the absenteeism or people covering up for others who come but they are not working properly because they're recovering from a night that, for example, that they drank a lot. They cause a huge amount of social cost to the communities, to society, obviously, within the family, but also to the society as a whole. Property damage, and these are not accounted in the numbers that we see only when we evaluate the impact of one condition or one person's drinking. Next. So to finalize, I just want to recommend the various virtual courses that exist in the PAHO's virtual campus. They're all available for free. They're for self-learning and can give you much in-depth information and education about alcohol and health and what can be done about it. Thank you very much.
Thank you, Dr. Monteiro. That was excellent. In the interest of time, we're going to move right on to Dr. Maharaj, who is HCC's Alcohol Policy Advisor, and he's going to talk to us about patterns and prevalence of alcohol use amongst the elderly. Dr. Maharaj.
Thank you very much, Maisha. Thank you very much to Trevor and all our other presenters for this wonderful session. I've really enjoyed listening to Kevin and Maristella. Thank you very much for excellent presentations. So we've been hearing a lot about the really global, regional sort of issues around alcohol. I wanted to just take us to an opportunity now to look at some of the research that has been going on in the region, specifically a project that I'm involved in looking at research in 4 Caribbean islands, and I'll tell you a little bit about those in a minute. And this just present one aspect of that research, which is looking at alcohol use among the elderly in the Eastern Caribbean, the association with NCDs and some psychosocial issues. Next slide. I want just to start, it's always nice to hear little stories because it sort of really brings it back to the real impact of where alcohol is, as Maristella was alluding to in her last few slides. And this is a quote from one of our MPH students from Yale who had done a project in Trinidad. It says, well, my dad, when he works and he gets paid, he does not remember he has a family. The first thing he does is goes to the rum shop or the bar. If he doesn't get money to buy his alcohol, he goes and sells my mom's jewelry, whatever he gets, animals, anything. When he starts selling everything, we knew he was an alcoholic and he could not do without drinking. And this is one of the many stories we hear from the region, and that reminds us that the real impact is at the individual and the family level, even though we have lots of numbers that tell us it's also at a population level. Next slide. Okay, so I'm going to skip through this because I think we've sort of covered some of the non-communicable diseases issues and the relationship with alcohol, but quickly, next slide. So the Eastern Caribbean is in a transition, very much away from the communicable diseases to the non-communicable, and there are high levels of non-communicable diseases in terms of cancer, in terms of stroke, in terms of hypertension. Next slide. And within the region, as you see on the columns on the left of your screen, diabetes and cardiovascular disease is one of the most highest recognized areas in the Americas. The Eastern Caribbean epidemic is the worst in the region and really compares significantly with other parts of the world. Next slide. Deaths due to chronic diseases will increase by 17% in Caribbean countries over the next 10 years. And this is data coming out of CARICOM. So we see here the NCDs being a major part of what both current and expected morbidity and mortality. Next slide. There have been many agencies who've been creating plans of actions to address NCDs, including CARICOM, including our Ministers of Health, the NCD Commissions, the CARPHA, the Healthy Caribbean Coalition, and PAHO through the stepwise approach to surveillance, building capacity, doing research and advocacy. Next slide. There have been many bits of research on alcohol issues in the Caribbean, but a lot of them have been based on things like psychiatry. There have been some studies on prevalence and early initiation and availability in youth. A group of genetic studies in Trinidad looking at the risk factors, especially among the East Indian population. There have been the STEP studies that have been conducted in almost, I think, all of the Caribbean regions. The challenge we've had is that no advanced analyses have been available on the STEP, so we don't know some of the subgroup analyses, the sort of high-risk populations and so on. And there have been two studies now that have been looking at the elderly. One has been recently published from Jamaica, and I'm going to present this current study, which looks at the elderly in Trinidad. Next slide. So let's go into the methods. Next slide. So the Eastern Caribbean Health Outcomes Research Network was set up in about 2011 with NIMHD funding from the US to establish a unique regional research infrastructure to generate action-oriented chronic disease research, to facilitate policy translation, local capacity strengthening, and community engagement in the Eastern Caribbean. Next slide. We have three aims, but really I'm going to focus on aim 2, which is to recruit and follow a community-dwelling adult cohort to identify novel risk and protective factors for cancer, diabetes, and cardiovascular disease. The study occurs in 4 islands: Puerto Rico, Barbados, Trinidad, and the U.S. Virgin Islands. Next slide. Next slide. So this is a community-based sample. In Puerto Rico and Trinidad, we have 1 or 2 representative communities. We use the entire island population in the US, VI, and Barbados. We have a random sample of adults. There's telephone sampling in the US, VI, and household sampling in the other islands. Next slide. Next slide. The eligibility criteria: you have to be English or Spanish speaking, over the age of 40, provide informed consent, must not be institutionalized, you have to have reliable contact and relatively permanent residence, since we'll be doing a second wave of study. In fact, we've already gotten funding, and that should start next year. Next slide. Next slide. So baseline data was collected on sociodemographics, self-reported measures, and clinical characteristics. We have community-embedded assessment centers, computer-guided interviewing, a brief physical exam, and biological samples for biobanking. Next slide. Data has been collected between April 2013 and May 2015. We have a baseline survey, which is a compilation of questions under 6 broad headings. They're all validated instruments and was extensively pre-tested. Next slide. For the study, we used the independent variables of ever drinking, current drinking, problem drinking, and heavy drinking. And the definitions are here. The ever drinkers were any kind of alcohol at any time in their life. Current drinking, using a single item, basically a yes or no if they are current drinkers. A problem drinker based on the CAGE questionnaire. And heavy drinking, which is consuming 5 or more drinks on a single occasion for men, or 4 or more drinks for women. And they were asked to report on how frequently this happened in the last 30 days. Next slide. Next slide. So we looked at dependent variables, psychosocial issues, depression, sleep disturbances, domestic violence, early sexual initiation, and the presence of chronic diseases. Next slide. We also looked at the association between the various levels of alcohol consumption and the presence of psychosocial issues and chronic diseases, and then other covariables in terms of ethnicity, education, marital status, religion, and the different island sites. Next slide. What were our results when we looked at specifically the alcohol use in the over 60 population? Next slide. So currently in the ECHORN, we've approached almost 3,000 people being recruited, and out of this, we have about 1,032 people over the age of 60, 67% between the age of 60 and 69, and 33% over the age of 70. Next slide. And this is the proportion of people from the different islands. We see 39% from Barbados, 26% from Puerto Rico, 22% from Trinidad, and 13% from USVI. As you expect, about 50% are of black descendancy, and the rest are quite mixed, including white, East Indian, Hispanic, and people who define themselves as being Caribbean. Next slide. Many of the participants are of lower educational status, 43% being less than high school, and a wide variety of religious affiliations. Next slide. 41% were married, 27% were separated or divorced. Next slide. When we looked at what's the proportion of the population with NCDs, we see diabetes at around 33%, hypertension at over 55% when you look at state defining either stage 1 or stage 2. About 13% had evidence of depressive symptomatology, and lesser amounts of less between 0 and 6% for things like cardiovascular disease. Cancer came in at around 7.5% to 8% of the population. Next slide. When we looked at what was the form of drinking, we saw about 70% had consumed alcohol at some point, about 21% were current drinkers, and between 5 and 6% were problem or heavy drinkers. Next slide. When we looked at where this the drinking was occurring, we found that generally problem drinkers were much more likely to come from Trinidad. We saw about 30% of the people who admitted to problem drinking coming from the Trinidad component of the survey. Next slide. When we examined cancer, only among the ever drinkers did we see a statistical association, and that's P less than 0.05, and that's people reporting cancer among the ever drinkers. This did not occur in either the current or the problem and heavy drinkers. Next slide. Those with stage 1 hypertension were more likely to report heavy drinking in the last month. Next slide. One of the most important things I think that we keep seeing in many of our studies across the region is the link between alcohol use and psychosocial issues. We find generally that those who are religious or spiritual are protected when it comes to alcohol use, but there was a strong association between all categories of alcohol use and the initiation of sexual activity before age 16 and having more than 5 sexual partners. Employed persons were more likely to be associated with heavy drinking or high-risk drinking status in the last month. Next slide. When we looked specifically at the 5 or 6% of the problem and heavy drinkers, those were people who reported having 5 drinks per occasion on 3 or more days per month. We saw that about 5% of the cohort over the age of 60 reported this type of behavior. 75% of these were in the 60 to 69 age group, and 70% of them were male. They tended to be married, tended to have low education, and were more likely to come from Trinidad. Now, interestingly, these people reported no economic change in their status over their lifetime, so that whatever economic status they had as a child, they tend to consider that as being the economic status under adulthood. They tended to be employed with high physical activity. Many were hypertensive and many were diabetic. So we see that this problem drinker being a slightly low economic drinker or person within the cohort. Next slide. So generally, the study found that there are wide use of alcohol across all demographic categories, and 5 to 6% of the cohort was involved in potentially harmful alcohol use. Males were more likely to be problem or heavy drinkers. There was association between alcohol use and stage 1 hypertension, and between ever users of alcohol and self-reporting of cancer. Next. In this population, higher proportions of those with low educational achievement admitted to high alcohol use in all categories. Further, those who were employed and possibly having greater disposable income were more likely to be drinkers in 4 of the 5 categories of alcohol use. Next slide. Participants who reported early initiation of sexual activity reported heavier drinking. Additionally, those who had issues with domestic violence, current or past experiences of this, had reports of problem drinking. Next. So how does our ECHORN data compare with other Caribbean studies? So if we look at abstainers, the STEP study in Trinidad reported an abstaining percentage of about 30. In our study, we got around 37%. Current drinkers, we see about 20% in ECHORN, about 35 to 38% in STEPS, and in Jamaican cohort published earlier this year, about 20%. Among heavy drinkers, we only had this for Barbados. We saw about 5% both in the ECHORN study and the SABE study published in 2007 about the same thing. So we think that we are very similar to most of the results around the region, so we think that we can believe the studies at least seem to be fitting quite well with what's gone before. Thank you. Next slide. The challenges we had, I think, is that one is that we have slightly different definitions of problem, heavy and harmful, and hazardous drinking between the different survey instruments, and it's something that maybe we need to look at a regional level, identifying how exactly we want to define these things and try to make it uniform. Plus, the STEP survey only went to the age of 64, whereas both the ECHORN study and the Jamaican study, we had people going up to 80, and in one person in Jamaica was 105, I believe. Next slide. So what's next? We'll have a follow-up with the cohort, and that will be occurring in the next 2 or 3 years, and we hope to be able to present that to you at some point. The challenge is, are we missing those who have the cancer? Are they dying? And because this was a cross-sectional study, maybe we're missing them altogether. So the cohort will have an opportunity for us to pick up on the next stage to see what's happening. Next slide. So in conclusion, we were unable to demonstrate strong associations between alcohol use and cancer or the NCDs among participants in this ECHORN cohort. Heavy and problem drinkers tended to be low-educated males living in Trinidad who were married and physically active and employed with high rates of hypertension and diabetes. 1/5 of the elderly currently use alcohol in a problematic way, and their associations exist between alcohol use and early sexual initiation, problem drinking, and current domestic violence, and having more than 5 sexual partners. Next slide. Thank you very much. I think we're just finishing on time. Sorry to rush this a little bit. We're running a little bit late. So I think this is just to tell you that this is our ECHORN cohort, my friends from around the region and from Yale. And now I think we can open the floor to questions. Thank you very much. Maisha?
Thank you, Dr. Maharaj. That was excellent again. So now we've had 3 fantastic presentations, and you can send questions via the chat, and I will have a look now for those. While we wait for questions, I wanted to ask a question to Dr. Shield just about women and breast cancer and the alcohol link. What kind of levels are we talking about that women need to be concerned about in terms of guiding their daily consumption or their consumption of alcohol in general?
So historically, this has actually been a very contentious issue. A lot of epidemiological studies started out with not enough power to detect whether or not there was a relationship between alcohol consumption and breast cancer at low levels of alcohol consumption, because the relative risk increase, or the risk increase per drink at low levels is not as much as at high levels. However, with research that's been recently published, we've seen that low doses of alcohol consumption, so consuming less than 2 drinks a day, is significantly related to an increase in breast cancer. So women who are consuming alcohol within current country guidelines of 2 drinks per day and even 1 drink per day are still at risk for breast cancer.
Thanks, Kevin. So I've got another question for you from Avi Biego. It says, Abby Bago, could the rate of cancers in the ever drinkers be due to their part drinking behavior? Were they heavy drinkers in the past? So basically, how does it link to their past drinking?
In here as well? Or...
Yeah, go ahead.
So the drinking phenomena of former drinkers being at higher risk is something observed across all epidemiological studies. And you'll see it with cancers in particular. So when we look at the epidemiological studies looking at breast cancer, lip oral pharyngeal cancer, we see that even if you stop drinking, you're still at risk for cancer 10 to 20 years afterwards. So these people are likely sick quitters that aren't showing up as heavy drinkers, but also we need to factor in that cancer isn't a disease that automatically shows up. It's also a disease that takes a while to develop and a while to become diagnosed as well.
Thanks, Dr. Shield. I just wanted to jump in here and let everyone know that we will be making the recording of the webinar available on the HCC website, which is www.healthycaribbean.org, and possibly through PAHO as well. And we will be sharing it in our roundup, which goes out next week, Friday. I'm going to go check and see if we have any additional questions. I've got one for Maristella. And this is really, why has the region done so poorly in terms of policy interventions, in particular around advertising? And do we compare with globally? Are they also doing poorly in this area?
Well, overall, in all policies, the region lacks a political commitment to act on alcohol policies in general. And I believe this is due to a changing political environment too. The new priorities came and sort of maybe shadow of the need to act on alcohol, or it didn't become easier to focus on alcohol per se. It became part of NCDs or is in road safety, but indeed, from a public health perspective, you need to look at the combination of problems and the whole impact on society. Now, on marketing in particular, there was more doubt on the evidence until a few years ago. The methodology used to assess the impact of marketing was also poor, but it has improved. And now we have a bulk of evidence from hundreds of studies, several meta-analyses that link the marketing exposure to the consumption. The alcohol industry on its own, they want to see, if you are exposed to this marketing, do you get a specific problem? Do you get cancer, or do you get dependent? It is, they put a burden on public health that is impossible to meet, and it was unacceptable for tobacco in public health, and the same now should not be accepted for alcohol. What is we demonstrated, or science has demonstrated, is the link between exposure and consumption and early initiation and heavy drinking. And that is in prospective effects and studies and cross-sectional. Now, countries are moving towards the control of marketing, but also this needs a global agreement, because there is so much in social media, in the internet, there is not regulated at all. And the industry knows that and is moving to target young people in particular through those new media. So we cannot stop just by regulating TV, radio, newspapers, journals, but it's a start. And we know it can have an effect, but the full impact will be seen when we can restrict the marketing everywhere.
And there's a role for civil society, therefore, a powerful role in advocacy, and armed with a lot of the evidence which is emerging to advocate towards governments and towards industry to create a more supportive environment. Dr. Maharaj, we have a question for you around your data. Were any figures taken from Tobago?
Yes, no, unfortunately, on the Eastern Main Road, and that was only because this population here captures very similar to the national sort of makeup demographics, and so that sample was used. To get to Tobago, it would have been very difficult just in terms of, because this is a cohort, we're hoping to follow these people up over time, and the transportation would have been very difficult. So no Tobago yet.
We've got one more comment as well. Very good and instructive presentations. There was a note that Haiti was missing, and it would be good to include Haiti. And that's point taken. So I think we're going to go ahead and close now. I'd like to thank again the Healthy Caribbean Coalition and our partners, in particular PAHO and CARPHA and CARICOM, for making this possible. Dr. Maharaj, our policy advisor, has been championing this issue for many years and really helped us to push this forward. Thank you, Dr. Monteiro, who's been always by our side, Dr. Prieto and Dr. Hannes at PAHO. Thank you, Dr. Shield, for working with us to put together this data and help us with the production of our infographic, which is available through our through our website, and also sent out through our roundup this morning. And as I said earlier, the recording will be made available. Thank you, everyone, for taking time out of your Friday morning to join us. We do hope that those cancer societies and other civil society organizations that are on the line who tuned in will join forces with the HCC to begin to advance our work in this area. Thanks again, and enjoy the rest of your Friday. Goodbye.
Bye.